next, and that's what that would look like, for instance, now you have a three-dimensional representation of a whole lobule in a fine delaceration setting. So these are the lobular structures. It's harder now to see the two layers of cells because you're looking at the whole thing. You have to look through it. But with a good microscope and a trained eye, you can still see the myoepithelial cells lining these structures, and you have the stromal component that is inside the lobule is still preserved in this setting. So this particular example has fairly rounded lobular structures. If you look at the next one, they're more finger-like. And this is a representation, this is just an example of the variability that you can see in a normal setting. Some are a little rounder, some are a little bit more finger-like. But
and that variability might occur with different ages, with different parts of the menstrual cycle, with different genetic background. I mean,
I don't, you know, we haven't done a controlled study of this, but I just know that when you look at these kinds of samples, you see a spectrum from one to the other. We know these are benign and normal, and it doesn't indicate a problem. Yeah.
Is there any relationship to the structure of the lobules and, you know, the things that you see related to the presence of cancer?
Yes, and we'll see some of that coming up. So we're still on the normal. We're going to move into all the abnormal stuff. Yes.
So is that FNA tissue just when you're looking at it, then do you put it on a slide and you're looking at it?
Okay. So you go in and you sample with a needle. So the needle, and you move the needle back and forth in the area so that you collect enough material so you have material to look at to make diagnosis. So it's then sitting inside the needle, and then you push that onto a glass slide, and then use another glass slide to very gently just spread it out on the slide. Either air dry it or fix it in alcohol, and then apply stains to it. And then this is what it looks like when you go in the microscope.
Can you speak at all about, like you mentioned, when you get surgery, like tissue from surgeries, you embed it in FFPE. How about for frozen sections of tissue?
Frozen section, if you have frozen, somebody is in the operating room and they want to know about the tissue while the surgery is still going on. That would be most often when somebody has sentinel lymph node done and they want to know if there's tumor in the sentinel lymph node, and sometimes from the breast itself. It takes too long to process it through formalin into a paraffin embedded situation. That would be the next day, and clearly we can't wait for that. But there's a shortcut. So you can take the piece of tissue and you put it into a cryomold. There's a medium called OCT. I'm not even sure anymore what it stands for. But you can use that instead of the paraffin, and you freeze it, and then you cut similarly thin slices from that frozen material and put it on a slide and stain it with H&E. And that you can have within 10 minutes. It goes pretty quick.
And for clinical research, sometimes you want to freeze away a piece of that tumor, and so you may take an H&E section to make sure there's something in it, and then you can just freeze it away. Is there another question?
And there's certain research, I mean, there's certain assays that you need frozen tissue for that doesn't work on paraffin embedded, and vice versa. So we like to have access to both. Yes? Okay, so here, I think it's my last normal slide. And this I thought was a particularly beautiful example of a ductile leading into a lobular structure. Here is one that's disconnected, and this probably comes off of the little side branch right here. Now, it's pretty rare to be able to happen to cut it this way. Mostly, I would say 95% of the time, all you see is disconnected globules and small ductures. All right, so here is the picture of where you can really see the two layers really well next to each other. So you have myoepithelial cells lined up really prettily here, and then you have the luminal cells on the inside. So this happened to be cut in a very favorable way where you can really see it. It goes actually from a fibroadenoma that has a slightly different type of stroma. You can see a little bit of that. It's a little more softer, a little more gelatinous than the typical stroma.
And a lot more cellular.
Yeah, it can be. There's more cellularity down here. It can vary in cellularity. your turn.
Well, just for a moment, but this is just to give us the
I
back and
think you
forth
have
with the...
another pointer right there.
Yeah, oh, good. Same color. So this is just to give us a sense of what kind of research projects are the people in the SPORE or other people asking about these samples that Britt is describing. So not only do you use it to decide, what is cancer, what is neoplasia, but when is it occurring, what's the progression pathway that you can maybe predict whether something is going to go on to a metastatic cancer. Because it's only down here at the end, generally, that the patient will die. Most of this, all of this really going up to then, is not going to be a tumor burden which is going to kill the patient. And yet, we start studying this to understand what's causing it, the genetic changes, when do they occur. So these are the questions. When does neoplasia, and we'll define that in a moment, occur? When is the first event? Which one of these stages does neoplasia occur? Is it genetic change, a mutation in the DNA, versus something that is a part of that, we call it epigenetic. It's not affecting the sequence of the DNA, but it might be affecting methylation or acetylation or something that changes the structure of the DNA. Can it be reversible, like epigenetic changes may be reversible, or is it irreversible as you get DNA mutations? What is clonal growth? Does anybody know what clonal growth means? It's sort of like the basic definition of cancer is if one cell takes off and starts growing, and that becomes the cancer, that's a clone of cancer cells, right? And so when does clonal growth start? When does it occur? Because that's really when you're talking about neoplasia. And when and how does it present? That is, show up clinically to the patient, to the physician. So what is neoplasia? It's not the same as cancer exactly. Each of these words, it helps to define it, and not everybody uses it in the same exact meaning. And so it's helpful when somebody uses it and they're talking about early changes and what's going on in the pathology, that you actually stop and ask them what do they mean. So it's a neoplasm is a new growth, and it could be any number of benign or malignant neoplasms. It's increased proliferation or reduced cell death. You can imagine that's going to allow the number of cells to increase.
So I've heard people say independent growth, that it's not dependent anyway, but neoplasia is, whether it's benign or malignant, grows on its own. It doesn't need any signals from anywhere else. It's sort of past that step.
Well, I think that if you look at different examples, some are independent and some aren't. So I don't know that I would agree with that. But you're right, that's another, is it independent or is it hormonally controlled still? Because some of them are. You can have a neoplasia. But then the neoplasia may show clonal growth or genetic alterations, whereas hyperplasias, which is still an increased proliferation, won't. So here's a distinction between a neoplastic event versus something which is maybe still under the control, as hyperplasias might be, of outside influence. Then there's malignant neoplasms, which are carcinomas. They grow, and by definition, what is malignancy? It means that it's not contained anymore. It invades through the surrounding tissue, and as it invades, it may metastasize.
And it also destroys the surrounding tissue.
As it invades, right. And especially breast cancer. I mean, there are some that don't, or some that grow by expansion and so forth. But carcinoma in situ is a neoplasia still. It's a new growth, which is not yet invaded through the basement membrane surrounding the structure.
So it's still in the duct system. Right. They may expand the duct system, but it's still contained within the duct system. All right, so this is still your picture there.
So I think there's just a couple more before Britt goes on, but I wanted to sort of get to a couple of ideas. And one of them is tumor growth. So if we talk about clonal growth, right, let's say what sets that off is a genetic mutation, in the DNA, so that cell now has uncontrolled cell growth, right? That one cell, the first one in the breast that starts growing in this uncontrolled way,